Here at ASCO 2015, Thomas Baldrick with Dr. Alban Chanan-Khan from the Mayo Clinic in Jacksonville, Florida. He's here to discuss a phase 3 study of Ibrutinib with Bendamustine and Rituximab in previously treated CLL, SLL patients. Thanks for stopping by, sir.
Thank you very much for inviting.
So let's begin. Why did you conduct this study?
This is a very, very important study. It's one of the largest studies that I know in relapsed CLL. The study was conducted to answer a very, very specific and important question. And that is that, can Ibrutinib prolong progression-free survival in relapsed CLL patients when given in combination with chemoimmunotherapy or Bendamustine and Rituximab? A little bit of background why this question is asked. CLL is an incurable cancer, and so the game plan all the time in management of this disease is to get patients into remission and try to keep them there as long as possible. So Bendamustine and Rituxan has been a cornerstone of treatment and management for these relapsed CLL patients. It does get them into remission, and it keeps them in remission for a certain duration of time, which is not very long. As Ibrutinib started to show its amazing potential in CLL patients, the obvious question was, can it also partner with existing effective therapies? So this is a large phase 3 trial that was designed to answer that question. BR is an effective and known established therapy for CLL. Can Ibrutinib add value and impact progression-free survival for patients? And it was done in the most rigorous fashion that you can think about in clinical research. So 578 patients were randomized 1-to-1, and they were given 6 cycles of BR, which is a very standard regimen, either with Ibrutinib or with placebo, and it was a double-blind study. And at the time of completion of 6 cycles, patients were either continued on Ibrutinib or placebo. Now, during the conduct of this trial, we learned that Ibrutinib is a very effective therapy, so almost it became ethical to those who were in the placebo-containing arm to be able to have the opportunity to receive this effective therapy. So the design was altered a little bit to allow those patients who progressed on BR regimen in the placebo arm to then receive Ibrutinib at the time of progression. And that does impact the overall survival curves at the end. But the design, even with this, has such impressive results that it is, as of now, altered how we will treat CLL patients in the relapse setting going forward.
What excites you most about the findings?
So there are 2 important things that I have. The scientific philosophy of this is that now we are able to give 3-pronged approach. We are able to institute 3 different mechanisms to fight the CLL. First is the chemotherapy part, which we knew. Second is the immunotherapy part of the Rituximab, which we knew worked. And now we know that partnering these chemoimmunotherapy approach with a targeted therapy can actually deliver enhanced responses. Now, primary endpoint of this study was progression-free survival. And that's, as I said, can we keep patients in remission longer? At a median of 17 months, we found that the progression-free survival has not been reached for patients in the Ibrutinib arm, whereas it is about 13 months for those who are on the placebo-controlled arm. So the primary endpoint was very nicely met. The hazard ratio of that is 0.2. Now that translates into an 80% reduction in the risk of progression or death if patients were on the Ibrutinib arm. That is phenomenal. That is just remarkable for patients. An 80% decrease in the risk of death or progression.
So do you feel this will be practice changing?
Absolutely, this is practice changing. So how does it actually change practice?
Right.
As I mentioned, BR is a regimen that we have been using to contain the disease in relapse setting for a very long time. Today, as of now, we know that BR is inferior because of the availability of Ibrutinib and because of the Helios study defining that Ibrutinib, when added to BR, is impactful in terms of the chance of going into remission, which is the overall response rate, is better. 2, the progression-free survival is better. And the chance of going into minimal residual disease is better. And the safety profile is very acceptable and nothing untoward. So all of these factors today advise us that if somebody has to get BR regimen or chemoimmunotherapy, they are better off by having Ibrutinib added onto it rather than not, because that triple combination impacts their chance of remission, their durability of remission, and perhaps their survival outcome.
Very well said. Thank you, sir. We wish you the best of luck. Keep up the good work. My pleasure.